2 a.m. and a patient comes into the emergency room. In the rural emergency department setting, you're not always expecting patients at 2 a.m. And one thing that I've had to coach providers on over the years has been dealing with those patients compassionately and being a good advocate. I bring up that example because as physician leaders, it's a good starting point. And we need to be the best advocates for our patients, for our communities. So how do we do that? Welcome to medicine. I'm Dr. Othniel Doolittle. I'm the CMO for Integritas, and I work in a variety of rural emergency departments. Today, we're here to talk about patient advocacy, something that's crucially important and dear to my heart. I love being a patient advocate. I offer it out to friends and family, and sometimes friends of family reach out, and I get to talk them through processes and be an advocate for them. And that's why we got into medicine in the first place. It wasn't the technology, the textbooks, definitely was not the EMRs. We wanted to help people and care for people, and we still have that desire in us. Sometimes, though, the system burns us down a little. As your team is worn down, how do you help them be better patient advocates? So when that patient comes in at 2 a.m. and a physician, unfortunately, is frustrated with them. What are you doing here? Did you just finish up with Cheetos and an Xbox and were bored and decided to come in for a workup? And that right off is a poor mindset. It makes it very difficult to accurately diagnose that patient because you're not listening to their story. One of the coaching things that I use is visualization of how that patient got to that emergency room. One thing that can be really fun, ask the patient, how did you get here? What were the steps? I've asked patients before too, how long did you wait in the parking lot before you came in? You'd be surprised at the answers. Sometimes they've waited for a while, considering whether or not they should go in, whether or not they will receive the compassion and the care, the answers that they're looking for. That shouldn't be the case. It should be an automatic, compassionate setting where our physicians are caring for people. They are pursuing their calling in medicine as caregivers and compassionate. When you think about how that patient got from their house, they looked at their bank account, they looked in their wallet, they try to figure out if they had enough gas money to make it. It is really, really rare that a patient would have lived right across from the ER and been bored and come over. There was something that drove them there, drove them, whether it was pain, their illness, fear. We think, well, you could look that up online and see this was simple. Have you looked it up recently? Dr. Google, Chat GPT, a lot of times you're dying of cancer and should be on hospice, or it's some terrible brown recluse bite that's about to kill you. And so you don't get the answers that you're looking for. And I understand that the technologies do have to nuance things and have a long list of it could be this, but that doesn't resolve people's fear about the problem that's in front of them. People are not trained. They don't have the experience that you have. And you are there to provide that compassionate insight into what is causing their pain, their fear, their illness. And a lot of times we can give them relief, whether it's psychological relief about the condition, or we have pain medicines there for them. We can treat something that's causing them great distress. And that is the beauty of medicine. I encourage you as a leader and your physicians, and as you encourage your physicians, that when you're filling out that EMR, you're typing, you're ignoring the patient, or you're trying to collect a bunch of data and then fill it out later into the system, very broken. But one thing we miss a lot is the story of the patient. Who are they? What brought them to that point? What brought them along that path of illness, injury, and why are they there? What is the story about them being there? We need to be good advocates for their voice and be able to bring out that story to help others and to help them. Being an advocate, being a good voice for the patient, is also about active listening. You need to ask, what else can this be? One of my best mentors in residency was Dr. Zane, who would always ask, what else? Don't just stop at one answer. Always ask, what else? And that goes for those patients that present. What else could be wrong? What else is driving you? I think I got one answer for you, but what else can I do to help you? There are a lot of things that we can't do. And so sometimes we shut down, we're burned out, we're overworked, and we don't want to ask those questions. But that's not being a good patient advocate. They'll come back, they'll have worse outcomes. In compassionomics, there are great studies about how compassion and advocacy, listening to patient stories, improves their survival, decreases mortality, decreases morbidity, increases compliance. We need to be compassionate advocates for our patients. We need to think about what brought them there, their story, what actually brought them there as far as their concerns, and then how they got there. What were the steps to get there? And you might see a deeper picture of your patient, have more compassion for them. And as you're teaching others, hopefully this grows you as well. Welcome to medicine. If this was helpful, please like and subscribe. And as always, feel free to reach out and we can have a discussion. Thank you.